Hi, everyone. My name is Kristen DeAndrade, and I am the division consultant for the Achondroplasia chapter of the Magic Foundation. I am also an advocate for individuals living with skeletal dysplasia and their families. And tonight we have our town hall, Achondroplasia, the most common form of dwarfism. It's an overview of expected height and options for intervention, as well as problems commonly encountered and treatment. It will be presented by Dr. David Feldman. Dr. Feldman is currently the Associate Director of the Paley Orthopedic and Spine Institute in West Palm Beach, Florida. He has been treating individuals with skeletal dysplasia for over 25 years. In addition to management, Dr. Feldman treats spinal stenosis, which is the most common complaint of the spine and reason for disability in those with achondroplasia. He also offers deformity correction and extended limb lengthening as treatment options. And we are also joined this evening by Dr. Aaron Huser. Dr. Huser also practices at the Paley Orthopedic and Spine Institute, specializing in the management and treatment of skeletal dysplasias. And he recently began prescribing BioMarin's new drug therapy, Voxzogo, to our patients with achondroplasia. So tonight, Dr. Feldman and Dr. Huser will be discussing achondroplasia and the problems encountered from infancy through adulthood, how to prevent issues that commonly arise, treatment of problems, expected height and possible intervention, both medical and surgical. Thank you, Dr. Feldman and Dr. Huser, for being here. Dr. Feldman, the floor is yours.
Thank you so much, Kristen. And I'm going to share my screen so they can see my slides. And I'll begin. So myself and Dr. Huser. Dr. Huser is a specialist in all not spine for achondroplasia, and I include my spine in my practice. But he probably is the world's expert at this point orthopedically on giving Voxzogo. So I asked him to join us, and he'll discuss some of the medical treatments as well, but certainly he's a surgical expert as well. But as Kristen said, achondroplasia is the most common form of short-limb dwarfism, and it occurs in about 1 in 25,000 births. And we know the gene that it's on. And about 80% of cases are cases where one of the parents was not a dwarf. It is new to this family as a spontaneous mutation in the chromosome that causes this skeletal dysplasia and achondroplasia. And don't get fooled, not all skeletal dysplasias are different. So even though names may sound alike, each one is a very, very different disorder, and each one has to be taken separately. So we're going to discuss the most frequent kind, and we're only going to discuss achondroplasia tonight. And I really hope that all of you who are listening, either live or afterwards, will contact us with any questions you have. I know there's many families of newborn children with achondroplasia, as well as individuals themselves who have it. So achondroplasia is common enough that when you go to the pediatrician, they should be able to map out how tall your child will become or how tall you will become. And it goes on an achondroplasia chart. And the more little numbers you put in with age tells you where you sit, even within achondroplasia, and how tall you'll be. And I'll discuss height during this period, during this talk, and we'll discuss that as well. But we know a lot about achondroplasia, and this is going to become important when Dr. Huser talks about drugs. We know it's a defect in a type of receptor on a cell and a protein. It causes a problem in getting cartilage to form. And it has some normal factors as well, but it has one defect, which he'll discuss, and it doesn't matter exactly what that defect is, but it's in what's called fibroblast growth factor. So we think about achondroplasia, we think about a normal trunk, but we think about the limbs being something called rhizomelic, which means that supposedly the thighs or the top parts of the arms are very short. That may not actually be true. The arms, it may be so, it may not be so completely with the legs, but the limbs are certainly short for the trunk. So the spine may be relatively normal height or standard height, while the legs are smaller. And also children and individuals born with achondroplasia are somewhat weaker, they're hypotonic. That weakness causes some delay in normal milestones, while many children who do not have achondroplasia will stand by 12 months or even walk by 18 months. It may take a child with achondroplasia 2 to 3 years to begin walking. And then there are some facial features associated with this and some contractures mean that the hips and elbows may not move completely correctly. The biggest problem in achondroplasia, both in adults and in children, is their spines. And then from the very infancy, we talk about certain things that occur. One thing that occurs, and we'll discuss, is foramen magnum compression. That's the spinal cord as it exits the brain and goes into the spine, it becomes compressed. The next thing is the children can develop a hunchback, which is kyphosis. They can develop a very tight spinal cord, stenosis. And that can occur also with a very sway back, which is severe lumbar lordosis. And very rarely they can get scoliosis. So I put this in order of importance in the beginning of a child's life. In the beginning of a child's life, something that myself, I don't treat, but neurosurgeons may, is something called foramen magnum compression. So that means as the spinal cord exits the brain, this is very, very tight. Now that's very important because the spinal cord at that point actually may control your breathing of the child. And that problem could cause something called sleep apnea, which means we all know that from adults who have it, or maybe you don't, but you stop breathing while you're sleeping. So in my opinion, all infants with achondroplasia should have a sleep study that determines whether or not they're having apneic episodes, whether or not they're stopping breathing while they're sleeping. Now, there may be two reasons to have that. One is their tonsils may be large, and the second reason, they may have stenosis at the foramen magnum. Now, while symptoms usually resolve by age 3, but not always. And the reason I'm showing the next slide is because this is something I see all the time from around the world. So we ignore the stenosis when the child's very small, and it actually injures their spinal cord. So if I could show you this gray color, that's the normal color of a spinal cord. That white is not normal. And children and adults may not even know they have it, but it makes them weaker than they have to be, and it makes them it may give them sleep apnea as well. Now, the importance of that in a child is, in an infant, is they can be decompressed. So if they're having neurogenic apnea, in my opinion, if they're having apnea not associated with an ENT or a tonsillar problem, then they should be decompressed by the neurosurgeons. And obviously that's only if there is MRI evidence of cord compression. And I feel very, very strongly about this, and certainly have many neurosurgeons in the past. What about kyphosis? So this is a child from a Netter drawing who has a round back, and that's what kyphosis is. And there's arguments about this too, whether this causes from sitting up too early in achondroplasia, or if it's just a factor in achondroplasia itself from being weak, the kids develop this kyphosis, this round back. Again, something that I don't like. I don't like kids to be sat up with achondroplasia until they can. When they can sit up, they can sit up. Until then, they can be reclining somewhat. And that also, I think, perhaps can prevent kyphosis. Perhaps it doesn't matter, but I don't think it's harmful, that's for sure. Kyphosis early on can be treated with a brace, as in this child. Or as in this adult, you can see how severe kyphosis can become. And there's the x-ray showing how the spine can actually change. So this is a normal vertebrae, T12. There's L1, the lumbar 1, and lumbar 2, which are triangular. And that, as we're going to see, can cause compression of the spinal cord as well. As in this case, where the spinal cord is coming over, being compressed at the kyphosis, and then going back. And that's called spinal stenosis. Now, spinal stenosis is caused by a number of different problems. But one problem is that the spine doesn't grow normally in children with achondroplasia. And that not normal growth of the spine will cause the spinal cord to become very tight. And as we become older and our spinal cords become more arthritic, everybody, whether you have achondroplasia or not, we develop arthritis in our spines. Our discs become somewhat dehydrated as we get older, and that causes even more narrowing. So by the time the patients are in their 20s and their 30s, by the time individuals are 35 years old, almost 80% could have spinal stenosis, and that's a big deal to have that. And so how do we know about this? Well, they get slow, progressive lower extremity weakness. Intermittent claudication means that they can take a walk and their legs begin to hurt them or get tired. It can happen in the neck or in the lower back or in the thoracic spine in the chest. And it can cause a paralysis acutely if something happens, if they slip a disc, if something occurs, they can develop acute paralysis, which is not uncommon in my practice to see patients arriving with acute paralysis. And this is the part that doesn't grow. So if you think the spinal cord runs through this tunnel, and these are called pedicles and they don't grow, that's where the body is and the disc is, then this is going to be a very narrow space because these don't grow. Does the medication make that grow longer, you can ask? I'll take that question now. We don't know that answer yet. We're hoping so. Maybe prevent stenosis. So kyphosis. So it usually presents in infancy. It's associated with poor muscle tone. It most resolve when walking, but not always. And there's this modification of sitting. So I believe in this, not everybody does, but basically the children should be somewhat, reclining when they're young and not sitting up at 90 degrees until they can sit up by themselves. And we can use a brace or do surgery when needed. And here's a young child standing up at age about 4 or 5, and you see that there's a kyphosis. The problem in this child is the spinal cord is also being very compressed at these levels. And that is the problem, because the children can develop acute paralysis, and this child did, or became very weak, and there's the spine fixed. And we can discuss why you use rods or not use rods, or do you have to use rods? It's a very big question in the achondroplasia community. And I think it's pretty straightforward. And we can discuss that if you have a spinal deformity and you just decompress, that will not work. If you don't have a spinal deformity with no kyphosis, then you can not have these rods and not have the fusion and still be doing just fine. And that young boy did fine. This is just more examples. As you get older, what I meant here, you could see a normal disc with normal fluid, and that's what it looks like when it gets dehydrated. So if you think, if this loses height as we get older, then it's even going to become more compressed as we get older. And so there, let's say this is the fluid around the spinal cord, that little dot there. There's no fluid anymore here. It's just completely dark. And that's what that's showing you, what's spinal stenosis, basically like a truck going under a bridge that it won't fit under. And that's it. So there's a normal spinal roots or spinal cord surrounded by that water, which is the white, and it can become quite compressed, as in this case. And what are the symptoms? Well, low back pain, leg pain. This is a burning nerve pain, numbness, heaviness in your legs, inability to hold urine, weakness as you walk along. And it's also often relieved by squatting. So we asked this questionnaire, and this is a questionnaire that's going to become very important, I think. And we are going to publish on this very soon as well. But basically, anytime I want to lengthen a child's legs with achondroplasia, we ask these questions. Anytime anybody lengthens the spine and lengthens the legs or limbs of someone with achondroplasia, should ask these questions, because you want to decrease the risk. And so, do you experience weakness? Are you losing your urine or bladder or bowels? Are you limited how far you can walk? Is that changing? Do you find yourself squatting after you're walking? Do you get numb after you're walking? And if you are limited, how far can you walk? Or how far could you walk a year ago compared to now? We may have to add that to this questionnaire. And then the treatment depends, as I said before, whether or not you have that hunchback or not, whether or not you need rods or just to open up the spinal column and allow the spine to move. Okay, what about lower extremities? So the average male height in achondroplasia is 4 feet 4 inches, about 131 centimeters. Average female height is 124 centimeters. What I said before about rhizomelia, this is actually Dr. Huser can talk about this maybe later, because he has to measure this for all his Voxago patients, is whether or not do we really have shortening of the thigh compared to the lower leg. I'm not sure that actually exists. It may only exist in 20% of patients with achondroplasia, not 80%. And then we have problems with bow legs, and it's called Varum in orthopedics, but bow legs is fine. You can call it bow legs. So let's talk about lower extremities for a minute. We can talk about lengthening. We'll talk about all of it put together. But that is the average height of a male with achondroplasia. Just remember these numbers as I talk about lengthening. So a woman's about 4'1", a man's about 4'4", and that's taller than many of the dysplasias. Bow-legged is present in about 50% of patients, and it can occur for a number of reasons. Patients with ligamentous laxity, it means they're like double jointed with achondroplasia, they can develop it. Being markedly overweight can cause it. And Arthritis is not common early on, but as people know, this can certainly occurs in achondroplasia as they need joint replacements as they reach into their third and fourth decades. So having a straight leg may help somewhat. So why do we fix bow legs? Well, if they're progressive, if it's getting more and more bowed, if the child or adult has pain, if there really is a lot of laxity, or if they're really thrusting. And what does that mean? So here's a young boy walking with achondroplasia, and you can see his leg thrust out when he walks. You see that little thrust, especially on the left side. You see the leg thrust out as he puts his leg down. And that's instability. So I'm going to show that again. And that's what bow legs look like in achondroplasia. Here's walking backwards. And now he'll walk towards us. And watch his left leg. That's on your right side. Watch it thrust out as he walks right there. And that's a problem. That is not easy to walk around with. So for that reason, often these children need to be treated. So there are many different treatments of bow-leggedness. And it's interesting that Dr. Kopitz would treat this with doing what's called a fibula. He'd take out a portion of the fibula. So we've been unable to find an article with the results of that. And we're actually, Huser and I were talking about that today, that we would like to revisit this from Dr. Kopitz, but he didn't write about this at all. And so it's hard to know the results of that. People have questioned whether or not because it's an easy thing to do to shorten the bone on the outside. I'll show you what that means, as opposed to breaking the bone, which we'll show as well. So you either break the bone or you shorten the bone. So here's a young kid, lateral thrust, and instead of using any fancy devices, you just use some wires, straighten the legs. His legs are straight, and there he's straight. So that's basically one way of treating this. There's a young woman who's much older, and she has what I would call, she has also thrust with pain. And just to show how you measure it, you figure out where the angle is exactly occurring, and then you put these frames on at the same time, and she can walk on these as an adult. She has a straight leg. Her ankle is parallel to her knee, which is parallel to the floor, and that's before and that's after. And at the same time, you can lengthen. So you can either just correct the deformity, correct the bow-leggedness, which gets rid of the pain, or you can lengthen and get rid of the pain. So what's the ultimate we can lengthen surgically? What can we possibly do? So one thing I'll say, going back to the spine, is that you cannot have severe spinal stenosis and safely lengthen limbs. So that has to be treated first. If stenosis is causing enough of a problem to cause someone to squat often, then you're putting someone at risk by lengthening your limbs because you're pulling on the nerves. So if you're doing extensive limb lengthening, these days we use internal rods for much of it to lengthen, meaning we don't need those devices I was showing you. You can get about 4 inches from the first surgery. This is all the max. 5 inches from the second, 5 inches from the third, for a total of 14 inches and 36 centimeters gain. So you're talking about someone who was 4'1" is now over 5 feet tall. Someone who was 4'4" is almost 5'8". So is that possible? Yes. So what is the problem with doing that? So there's a number of problems with doing that. Number one, I'll go to the second one first. The time involved. You're talking about taking someone away from their life 3 different times for what may often take 6 months out of their lives at least. So you're talking, it's a very, very difficult procedure. It's a lot of physical therapy. It's painful. And so is it worth it? It's not for me to decide, but it is possible. But you may have to stop short of this if you're having complications. Are you getting contractures of the joints? Are the joints dislocating? You need a lot of physical therapy. And that's why at Paley Institute, we basically have it all set up for this with our physical therapists and child life specialists and family places to live. But they come down for a long period of time. Does all that pressure from lengthening cause premature arthritis? Maybe it could. Arthritis can cause from pressure. There is a risk of neurologic injury from doing this, from doing too much lengthening. And that's why we're very careful to get MRIs of the spine before we begin lengthening. But at least to know that is what extensive limb lengthening is. And that's how many inches one can gain, or at the most one can gain from doing this. What about upper extremity lengthening? I think this is very important, something I do very frequently, because it really involves activities of daily living. Certainly if someone has had a spinal fusion, they can't bend forward and their arms are very short, it's very hard to take care of yourself, both going to the bathroom or eating or reaching reaching out in front of you, reaching into a closet. So there, it's a lot easier to lengthen the arms. We can do both simultaneously. It's between the shoulder and the elbow. We can get 4 inches all at one time, which is about 11 centimeters, and it's well tolerated. The patients usually go home after about 2 to 3 weeks from Florida, and we follow them with x-rays from wherever they live around the world. And it seems to be a really quite useful operation for patients, and they really feel that they gain a lot of function in activities of daily living from lengthening their arms, because that often becomes a problem, because that is where patients with achondroplasia are rhizomelic, meaning that there's a lot of shortening between the shoulder and the elbow, as opposed to the elbow and the hand. So how do you do that? Here's an arm. So sometimes we can use a rod if it's very long, but the first one, you really have to use a fixator. And this is what it looks like. You break the bone, right? Here it is. And here's a lengthening there. You're lengthening and the bone is filling in. So let's look at the dates of this, just so you see how long things take. This is on, it's reversed. So this is June 18th, 2020. July, August, 2 months, right? 2.5 months, 3 months. And now we're at over 5 months. So 5 months, we've reached 11 centimeters, and these frames are basically ready to come off when we put a rod in. So we've lengthened from here all the way to here. We've lengthened this 11 centimeters in this young man, and he had both frames taken off at the same time and had a rod put in and did fine. And that's usually the measure. So I'm going to hopefully be able to give this over to Dr. Huser to speak a number of minutes about Voxzogo, which is the medical treatment for height. I will say that neither one of us want to discuss the moral issues and the choices people make. We can give the risk, benefits, and alternatives. Is short stature a disability? I'm not an ethicist, nor do I have the answers to this question. Certainly in modern day life, there are disabilities from having extremely short stature in life. Is that warrant doing a medical procedure? That's not my decision to make. I do think it is a feasible procedure to do safely, but I'm not against people who choose not to do lengthening, and I'm not against people who choose to do lengthenings. And so I want to leave that also with the medical, as he discusses the medical treatment, that again, we're not advocating to use the medical treatment. We're saying it's a choice. It's a possibility to use, and here is what it looks like. So hopefully I can mute this, and Dr. Huser, I can see on here, I think he could probably speak without. I may have to stop sharing. Can you speak? Now try now, Aaron. Try speaking.
Can you hear me?
Yeah, I do. Great.
Okay. All right. So Voxzogo is the once-a-day injection by BioMarin. To be eligible currently, you need to be you need to be at least 5 years old, and you need to have open growth plates as well as a diagnosis of achondroplasia. So how does it work? It's injected once a day. You try to switch that spot. It can be in the abdomen, on the thighs, in the buttocks, and it can be on both sides. You try to do it at the same time every day. And it's a C-type peptide that helps accelerate the growth plate, where FGFR3, which is the mutation in achondroplasia, puts the brakes on the growth plate. So they sort of act, the Voxzogo tries to speed up the growth plate so the mutation in achondroplasia won't slow it down. What are the results? So there were some questions before our presentation, and someone asked, I'll pull it up, asked, I heard the response effectiveness of treatment varies greatly in younger children. More growth improvement noted in older children. Is this true? Yes, actually, that's a great question. They did find that in the 8 to 11-year-old group, there was a 2.32 centimeter improvement versus the 5 to 8 group, which it was 1.35. If you look at all the patients who had Voxzogo in the study, there were 60 that got it and 60 that didn't. They found that the patients that got Voxzogo, which is the blue box on the far right, was increased by about 1.5 centimeters per year. So if the average is 4 centimeters of height growth per year, which is about 1.5 inches, and you're on Voxzogo, that becomes 5.5, which is just over 2 inches. If you look at the left part of this graph, you see the blue and the orange are close together. That's showing that the patients before they got Voxzogo were pretty similar in characteristic and weren't different. And then again, when you look over at the right side, the blue got Voxzogo, the orange did not. And you see that that blue is different than the orange in its space. And that's showing how it improved their average annual growth velocity. One question we get is, what about the side effects? So the most common side effect was injection site irritation, which could be redness. It could be a little bit of swelling. In my current experience, where we've prescribed about 25% of all Voxzogo prescriptions, I've had one patient who was on the older side, about 14 years old, that dropped out because they just didn't want to do the injection and they wanted to get lengthening. Which brings up another point. You can have Voxzogo and undergo lengthening if you would like. And then I've had one patient also tell me that it hurts a little bit when they give the needle, but there were no real severe side effects such as death or permanent injury. The one thing they warn people about is to eat or drink something about an hour to half an hour before you take the medicine. Because of how the C-peptide works, you can actually decrease your blood pressure just temporarily for a little bit. And they just want to make sure everyone has enough fluids on board so that that doesn't happen. Other than that, that is Voxzogo. There are a couple other trials going on right now that are open. And someone had asked a question about Theracon. Oh, if my child is already taking Voxzogo, will he qualify for the Theracon trial? I looked at the current trial inclusion and exclusion criteria, and if you're on another growth modifying medication, you would be excluded from that trial currently. That was for Theracon, and I imagine that's for the other ones as well. There's another C-peptide that's just a weekly injection, and then there's another drug that attacks the FGFR3 receptor or FGFR receptor directly. That's it from my side. Kristen, did you want to ask those remaining questions, or should we just answer them right now?
Yeah, if anyone has questions right now, you can type them in, and Dr. Feldman and Dr. Huser are here to answer your questions live.
Can I just go ahead and answer the other email questions that were submitted?
Sure.
Sure.
Okay. So when will vosoritide be available to children under 5? Our granddaughter is 5 months and we're anxious to get her started. So they just finished up their phase 2 trial in patients 3 months to 5 years of age. That's a safety trial. So the next one will be a phase 3 trial looking for effectiveness. Their first phase 3 trial, which is the one that was just completed, took a year. So I would imagine in 1 to 2 years, if everything goes as planned, it would be available. That's the same for, what are your thoughts on Voxzogo? Do you think it will be approved for under 5 years old in the US soon? Yes, I do. What qualifies a child under 5 to get Voxzogo for off-label use? So there is actually a trial currently for Voxzogo, and that is if you have severe foramen magnum stenosis. There is a trial for those patients to get on for Voxzogo. I think they're looking for 20 patients, but you have to have foramen magnum stenosis, and that's a tough one in terms of, would you rather just get that decompressed? Which I agree. I think I'd rather just get that decompressed than enroll in that trial. And then Dr. Feldman, this one might be for you. Is there a way to ease breathing pauses at night? Our child is almost 10 years old, has passed 4 ENT surgery, is under neurosurgical follow-up where everything is fine. So they're pausing at night.
Yeah, so my question is, why are they pausing? And I think that I would really either get a second opinion from the neurosurgical part or the ENT part, but I understand they cleared the ENT, but that means it is neurogenic. So love to see that MRI of the neck and the brain to see whether or not there is any foramen magnum stenosis. I mean, if they don't have any foramen magnum stenosis and they have nothing in the ENT, then really it's just a matter of using, some kind of BiPAP machine. I mean, I think that's just dangerous. I mean, having someone having apneic episodes is dangerous. And oftentimes it's a battle with neurosurgeons who don't see a lot of achondroplasia to make them understand the need for this. And I showed those changes in the spinal cord. So many people from around the world with achondroplasia are ignored. And I've gone to conferences everywhere in Europe and even in Asia, and I see kids coming in wheelchairs, young kids, I'm ventilator dependent because they didn't have a decompression. So I am, even though I don't do that surgery, I am very much an advocate of kids early on getting themselves decompressed if they're having apneic and any evidence at all in the MRI of stenosis.
So maybe
Okay.
just my ignorance. So do you think an ENT, when they say that they've had the ENT, they passed ENT trials, that's a sleep study? Or do you think that they need to get a sleep study? Like, it sounds like they need a sleep study to document these pauses and.
Exactly right. So I think the problem is that what happens is you have these pausing episodes, were really apneic episodes. So that's a sleep study. The sleep study tells you that. One cannot tell the difference between neurogenic apnea and ENT apnea. Nobody can tell you that. What the ENT could tell you is you don't have large tonsils. There's nothing physically wrong with your pharynx that's causing you to, or your larynx or any part of your airway system that's causing you to have apnea. If that's the case, then you really need an MRI of the spinal cord. If there's any evidence of foramen magnum compression, that needs to be decompressed. So I don't think they can tell. If you have a combination of the two, then have both decompressed, have the tonsils removed or whatever, and then have the foramen magnum decompressed. So I think this is something that I certainly stand on a soapbox about. And I feel like sometimes I'm fighting with a lot of people about this. I mean, there's many advocates on my side from the neurosurgical part, but I do think that we do find ourselves having this battle between, who should get the decompression or not. Are there other questions, Kristen, from the audience?
Yes. How long would someone stay on Voxzogo treatment? Do they take it until the growth plates have closed?
Yeah, there's 2 points for this. Yes, I would take it till the growth plates close, or that you're not getting any benefit from it in terms of height. It would be, it's once a day for Voxzogo. It's once a day, every day. And as long as you're not having side effects that prohibit you from taking it, yeah, you take it until they close. The other thing I didn't bring up is that we think about height, and Voxzogo is going to affect height, yes, but it's also going to affect arm length. And that's, like Dr. Feldman said, I think one of the most functional things that any patient with shorter arms can experience. Not only that, if you take Voxzogo, you may obviate the need, which means you won't need to have an external fixator if you want to go have further lengthening, and you could just go right to internal lengthening, with nails. And again, very personal decision, very personal choice on whether or not you even want to be lengthened. But it does have Voxzogo does have those other benefits as well. I don't work for Voxzogo. I don't get paid for Voxzogo, so I just want to put that out there.
And I think one thing, what he's talking about is that, when I mentioned the extensive limb lengthening, we talk about 3 surgeries. Maybe Voxzogo could eliminate one of those surgeries. If it does that, then, if you wanted to gain 13, then you can go right to rods, what you call nails. You can go right to these self-lengthening rods and not have to wear those devices that I showed you. So I think all these things are factors involved. And again, I think he just said, we're not judging who should do this. We're just saying how you do it. Any more?
Okay, from an orthopedic standpoint, how frequently should MRIs be completed to screen for foramen magnum compression? And is there an age when this should or could stop?
Yeah, that's a great question. So the answer is 0 to 3 is really the time. I mean, after 3, unless there's symptoms involved, there's really no need for an MRI for foramen magnum stenosis. You really come into the more lumbar stenosis, right, if they're symptomatic. So you take the questionnaire. It's the 0 to 3-year-old that really needs the MRI. And I only get one. I mean, I think that I do this, the kids have a sleep study. Do they have apnea? Do they have an ENT problem? Means do they have large tonsils causing the problem of the apnea, if they have apnea? If they don't, an MRI does it. If it shows foramen magnum compression, there is no reason to wait if they're having apneic episodes. No reason to wait. And I cannot focus on that enough. It's a time bomb. And you can get away with it sometimes, but you don't always get away with it. And I've seen the problems. Not even people don't even know they have those problems. The MRI I showed you was a 16-year-old who lived a normal life, had no idea that they had spinal cord changes. And it just made that person much weaker than they had to be. They didn't know they were weaker than that. They were fine. But eventually that will catch up to them as they get older. So I think that 0 to 3 is that age. You know, the baby should have an MRI, really is, they have an apnea study done at 3 months of age, and then basically an MRI if it shows apnea, and then go from there.
If there are any other questions, you guys can submit them in right now. We don't have any more. Thank you both so much for being here. I think you've answered a lot of questions and people have found it really helpful. Any other questions?
All right. Well, orthopedic surgeons beat Eric's thought. He thought it would take an hour and a half. We did it in 40 minutes, Eric. I don't know.
All right, we have one more. Hold on. Does Voxzogo help rhizomelia significantly?
So we don't know that answer. They looked at proportionality of the upper and lower extremities in the original study for the phase 3 study, and it didn't have any change between the uppers and the lowers. I do not think they've looked at radiographs. There are some studies going on looking at x-rays and looking at rhizomelia. A lot of patients are asking about proportionality, and they think about the spine being larger than their legs. And that we don't know the answer to yet either.
And that's a really interesting point, is what's going to happen with the spine with Voxzogo. I'm very interested in knowing that answer, and we don't know it yet, because to avoid stenosis would be a game changer in terms of the issues of achondroplasia as they become adults, because that is the biggest problem. So I would hope I'm hoping that we see changes in the what's called pedicular length, the length of the pedicle, the height of the vertebrae in width, in from back to front. All right. Well, on that note, okay. So on that note,
no more questions.
Well, we thank you guys for Kristen. Thank you, Eric. Thank you for setting this up for us, and Dr. Huser. Great discussion. We're happy, just reach out to us. We are certainly available on our websites and, through emails to ask us questions if you've thought of some that you want to ask us about. But, these are definitely a passion topic for us, for myself and Dr. Huser, in terms of the treatment of achondroplasia. We think that there's so much more that could be done to make individuals' lives normalized, and from every standpoint, from eliminating pain, from eliminating dysfunction, and we take it very seriously. So happy to really answer any inquiries that you have down the road. So I want to thank the Magic Foundation, and Kristen, thank you very much.
Thank you. And if you guys have questions, you can feel free to reach out to me through the Magic Foundation or in our Achondroplasia Facebook group, and we can put you directly in touch with Dr. Feldman and Dr. Huser to get your questions answered. All right. Thank you guys so much. I think that'll do it.
Hi, Chris. Thank you.
Have a great night.
Thank you.